It's the Dr. Professor Elmer Tu.
Hello.
So Professor Elmer Tu is going to give us a talk on Acanthamoeba, which I've actually keyed him in to tell us about what do we know, and I've called the bug a very bad bug. So let's see what he has to say about it.
Great. So we look forward to hearing from Professor Elmer.
Thank you very much, and thank you for the earlier introduction. One thing you left out was that I'm the other fellow from Bascom Palmer the year that Jim was a fellow there. So yes, that's probably my greatest claim to fame. All right, let me go ahead and share my screen here. So today what I was asked to do is to go over Acanthamoeba keratitis. Now this is certainly something that's probably a little less seen among all of the other infections that are very common, including HSV, fungal, bacterial, etc., that you all see in common practice. But it is an important infection and something that often will lead to failure if it's not recognized. And recognition is really the major factor here. If you look at all of the things that are controllable in terms of coming to a good outcome with one of these infections, it's really early recognition. Any delay in recognition is the most common controllable factor that will lead to a poor outcome. Once you recognize the possibility of Acanthamoeba, you want to go for a specific diagnosis if that facility is available to you, and then start prompt aggressive treatment. And the reason for this is that Acanthamoeba keratitis is not an infection that will be cured in a day or two or even a week. You might see in bacterial keratitis. From clinical presentation, it's a very long and winding road for these patients. In order to get the medications they require, get an accurate diagnosis, and then the treatment course is non-linear. And I always mention this to people who manage these patients, is that these patients will do better for a period of time, then worse, then better, then worse. It's psychologically wearing, really, both for the physician and also the patient. So what are we dealing with? Acanthamoeba, as you know, is a free-living protozoa. It's found ubiquitously. It was first identified as an eye pathogen in 1973, but it's found everywhere, all around the world. And most of the outbreaks and infections can be traced to water. And we think of recreational water or pond water, but also household water is a problem. These are older studies, but you can see that as part of the burden of Acanthamoeba, it's relatively low percentage-wise in India. But in China, very clearly, you can see that there are places where the incidence varies quite a bit based on how many people are wearing contact lenses. And this is also pointed out in study in Brazil, which showed that as the country became more affluent and people started wearing more contact lenses, that the incidence of Acanthamoeba keratitis rose. So it's very important to understand what the risk factors are for Acanthamoeba keratitis, which occurs primarily in contact lens wearers in Western countries, but in any country can also be related to trauma and other exposures. Our experience really comes from over 300 cases that we've seen over the last decade and a half or so here at UIC. It's a continuing problem, as you can see here, just from our case counts year by year, that really hasn't decreased significantly. So what is it that would clue you in as to the possibility of this being Acanthamoeba keratitis? And you can see below, there are a number of different photographs. I think all of us would recognize that the central one would be highly suggestive of Acanthamoeba, but the patient on the left is also a patient with Acanthamoeba. So when you see patients, we know the risk factors are what will initially pique your interest as the possibility of Acanthamoeba keratitis. Contact lens wearers, as I've already mentioned, soft contact lens wearers and rigid lens wearers are really the ones at most risk, at about approximately the same risk. As orthokeratology becomes more popular, this has also been a risk that we've seen here in the US, and we have a paper that's currently in press and being in eye and contact lens, which shows that even in the US, orthokeratology is a risk. So that's something that's gaining increasing penetrance in India. It's something you should watch out for in these particular patients. And then, as Jim was talking about bilateral disease and atopes, there's actually a fairly high likelihood of a patient having bilateral disease, either presenting at the same sitting or sequentially over time. So the same risk factors that the patient has at home, but probably also their own immune systems probably have some exposure to risk that allows both eyes to be affected. There is no relationship as far as I know with atopy in these particular patients, but we have seen repeated infections in some. So acanthamoeba keratitis initially is not something that is a infection that causes a great deal of necrosis. And so this patient that I showed you earlier, this patient could be easily mistaken for dry eye. You can see the epitheliopathy in the picture on the right. One of the keys here is, though, in these patients that epitheliopathy usually stops before the limbus. There's usually a 1 to 2 millimeter area of clear cornea peripherally, which tells you that this is a central corneal problem, and this is a patient who would be at higher suspicion for acanthamoeba keratitis. Along the vein of dendritic keratitis, nearly 2/3 of patients who present to us with acanthamoeba keratitis were previously treated for HSV. And you can see here, this is a patient with acanthamoeba keratitis with what's known as pseudodendritic keratitis. These don't obviously have the form or the terminal bulbs you would expect to see in HSV, but you can clearly see the radial neuritis. That probably developed later, and the initial clinician that saw this patient would have easily been fooled into thinking that this was HSV primarily. So a patient, as Jim was talking about, if they don't resolve in a reasonable way, you have to consider the possibility of acanthamoeba keratitis in these patients that appear to be herpetic but may not be. As I mentioned in the previous slide, radial neuritis is a hallmark, a pathognomonic sign that you would see in these patients. It's probably seen in only about 1/3 or less of patients, but if you see a radial neuritis, you want to think about the possibility of acanthamoeba keratitis very strongly. It has also been described in other infections, including Pseudomonas, but the vast majority of these patients are going to have acanthamoeba. And as I mentioned earlier, once they get to a ring infiltrate stage, the diagnosis and the recognition of this particular disorder is much easier. This sort of classic Wesley ring with a central area of clearing, or even the deep stromal keratitis you see here on the right. Again, a mimic of HSV, but in these particular patients, so they have risk factors, unusual pain, and some are lacking some of the findings of HSV. You want to consider in these patients very strongly that they may have acanthamoeba keratitis. So it can masquerade as a dry eye, other subacute infections, including fungal infections, microsporidia, herpes, and the vast majority are really treated for other diagnoses prior to coming to the attention of somebody who has a diagnostic capability of diagnosing this infection. So it's absolutely critical that the clinician understand the risk factors associated with it so that you can recognize and diagnose these patients early. In addition to the presentations I showed you earlier, something that may be more apropos in your practices is that this is often a polymicrobial infection, meaning that patients with acanthamoeba often present with other infections, including Pseudomonas, fungal infections. It's been described with HSV, and also other amoebic infections. So if you have a patient who is not responding appropriately to therapy that you expect to work, you want to consider in your differential the possibility of a secondary acanthamoeba keratitis that's also present at the same time. And this has really been described throughout the history of its known life of acanthamoeba keratitis ever since the 1980s. And why this is important as far as recognition is concerned, that patients do better if you get them at an earlier anatomic stage. As Dr. Chodosh was mentioning earlier, if this is something that affects only the epithelium or the anterior stroma, the likelihood of a good outcome, meaning visual avoiding transplantation, is about 10 times greater than if you diagnose this at the stage of a ring infiltrate or a deeper keratitis. So it's extremely important in that sense to recognize the possibility early so that you can make the appropriate adjustments to your treatment plan. So in contact lens patients specifically, if they have any risk factors, just remember that acanthamoeba keratitis needs to be on your differential diagnosis list. As far as diagnosis is concerned, generally you can, in the later stages, you can diagnose these patients with a ring infiltrate sort of by clinical history and examination. But in the earlier stages, you're really going to be reliant on other studies, and that includes microbiologic methods. Non-nutrient agar with Enterobacter is probably the most commonly available media, but even then, laboratories struggle somewhat to identify this microbiologically. You have excellent laboratories there in India, and I know that even with a simple KOH prep, the sensitivity and specificity can be quite high in the 80 to 90% range. So I would definitely seek out a microbiologist who is familiar with the diagnosis of Acanthamoeba. And I think there is a great deal of expertise in India, probably better than here, that can help you with that. Imaging, if you have it available, confocal microscopy, I think is now proven to be a very useful adjunct. But it's very important really to try all avenues of diagnosis, because very often you'll only find one of these to be positive, but that will make the difference in your patients in terms of their prognosis. As far as molecular diagnosis, this is becoming better and better with each passing month. As PCR is validated for this, it has about equal sensitivity, interestingly, to in vitro confocal microscopy in most of the current studies, but hopefully as the tests improve, that will improve as well. So as far as routine medical therapy, this is where a challenge comes in, and that is that much of the routine medical therapy that's used for Acanthamoeba keratitis is not something that's easily commercially available. Debridement, which was talked about with HSV, is probably helpful to a certain extent, especially in epithelial disease. We usually use a combination of medications, including some sort of diamidine like propamidine or hexamidine, along with a biguanide, and that's either chlorhexidine or PHMB. Unfortunately, the chlorhexidine and PHMB are compounded currently. My understanding from Dr. Dart is that they are going to have commercially available PHMB in Europe within the next year or two, now that it's finished its studies. We'll talk about some systemic medications and the role of steroids as well. So this is what you hope for, is a patient with a very early disease. This is a 16-year-old soft contact lens wearer with pretty much only epithelial disease. And you can see very clearly the irregular pattern of the reflected light off of the iris here. She was positive. We started on chlorhexidine, did a mechanical debridement at the time of her visit. Within 10 days, her vision returned to 2015. We treated her only for a month in this particular case, and she had no recurrences afterwards. So this is an ideal situation where you identify a patient early, are able to mechanically debride them and treat them for a relatively short time with good success. And really, if you look at the results from Acanthamoeba keratitis in the past, the visual results have actually been pretty good if you compare them to bacterial and fungal keratitis, mainly because there isn't a lot of initial necrosis in these patients. So if you are able to treat them medically, generally they do reasonably well visually. We have found recently, and it's been published out of the Wills Eye Institute, that more recent cases are becoming more resistant to therapy. They're requiring more time in order to resolve their infections. They're getting poorer outcomes, and they're needing more drugs. This is our personal observation as well. And in talking to Dr. John Dart from Moorfields a couple of years ago, they're also seeing the same problem. So it's unclear whether this is an issue with the medications or the organism itself is changing in some way, but more recent evidence suggests that visual prognosis is less favorable than it had previously been. As far as treatment failures are concerned, very briefly, the things that I'll talk about are extracorneal disease, the possibility of drug resistance, and then also very briefly at the end, surgical management. Like all infections, prior corticosteroid treatment of any kind results in a poorer outcome. So the lesson here is basically, if you have a patient who has an unknown keratitis, which is not responding properly to either bacterial or antifungal therapy, that the addition of steroids, if they have Acanthamoeba, is going to worsen their prognosis. So if you have a thought that that may be there, you want to definitely pursue specific diagnostic tests to make sure it's not there, but prior corticosteroid therapy is unhelpful in these patients. These patients, interestingly, also have a wide quadrante of extracorneal disease, mainly non-infectious things like dacryoadenitis. They can get a non-infectious scleritis. They can also get an infectious scleritis, as well as other adnexal disease. So these patients not only have corneal disease, but they may get a choroiditis, and these are often inflammatory and not infectious. So as far as immunosuppression is concerned, John Dart's article back in 2009 really highlighted the importance of using immunosuppression in those patients who are appropriately treated with anti-Acanthamoebal drugs. So while prior treatment is bad with steroids, after beginning treatment, it is often necessary in many patients who have either extracorneal or adnexal disease to consider immunosuppression. If you don't immunosuppress these patients, unfortunately, they can get a severe scleritis and end up with a tisical eye from ciliary body shutdown. So it's important to walk that fine line once they're on therapy. And then briefly, as far as strategies, these are some of the strategies if your standard medications don't work. This includes the use of benzalkonium chloride containing compounds early on in the process, which can help with epithelial forms of disease. A recent study out of Moorfields showed actually that propamidine, most of the anti-acanthamoebal effect comes from the benzalkonium chloride rather than the underlying propamidine. So benzalkonium chloride can be a partner, especially in those patients where you don't have access to treatment immediately. So the use of a non-BAK compound or antibiotic would not be preferred in these patients where you suspect acanthamoeba is a possibility. Pentamidine is another diamidine that's in that class, which has been used in the past. It's extremely toxic, and evidence for its utility in these patients is somewhat limited. Most of the azoles don't show significant activity against acanthamoeba, and the exception of that is going to be voriconazole. Either oral or topical has been described as an adjunctive or even a primary therapy in a couple of patients that we had for deep-seated acanthamoeba keratitis. But I find that this is not consistently effective in most patients, but can be helpful, especially if it's the only thing you have available. The newest class that's interesting is alkyl phosphorylcholines, primarily miltefosine. You can see here, I'm not going to go through all of the complications, but it's a common drug used for leishmaniasis around the world. Actually, it's probably the drug of choice now. This was the first patient we treated in 2011 on an experimental IND basis. You see this patient had multiple recurrences after 2 grafts. We started the miltefosine, and the patient was able then to clear her infection and actually maintain 20/60 vision for quite some time with a clear graft on the bottom right. I know Bhupesh has really pioneered this from a topical treatment. It does have some effect, obviously causing some inflammation in the eye. We've looked at this in our own patients. We've had 13 patients, all of which have done well. We have had a couple of failures as well, but generally this is much more effective. It's probably the most effective oral medication we've had access to. Not 100% effective, but certainly more effective than voriconazole. And then the last thing I want to talk about is surgical management. If you have acanthamoeba that's central and you know the borders, I think a traditional PKP or a DALC in these patients actually does quite well. As you start to get larger, these patients, unfortunately, you start to get into their drainage angles and into their iris. Large penetrating keratoplastics can work if you can avoid those areas. You can see in the photograph here on the right, this patient did very well just with a large 9.5 millimeter PKP. But if you're suspecting, as in many patients with acanthamoeba, that there may be extension either to the limbus or into the sclera or into the very peripheral cornea, that can be a significant problem. And in this particular case, recurrence in a transplant usually will take this appearance, this sort of crescenteric advancing area of granularity. That's usually a fairly advanced sign of reinfection of a transplant. In those cases, when you have to go larger, doing a standard trephination into the peripheral sclera can cause significant derangement to the drainage structures in the eye. So our preference has been really to go horizontal. And you can see here in the schematic, this is essentially an extracapsular cataract wound entering just anterior to the trabecular meshwork and removing both sclera and cornea in these patients, but leaving behind many of the vital structures. So this is a scleral keratoplasty of a different type, where we basically replace a horizontal incision rather than a vertical one. And I don't know, in the interest of time, we can go through this quickly, but basically this is a dissection all the way around 360, as you can see here. You're going about 80 to 90% depth, and this is taken 360 degrees. And then here, using a crescent blade, an initial entry is made up into the gray line. And then that's taken also 360 degrees around the cornea, so that you're basically left with an extracapsular cataract wound that goes all the way around, or a scleral tunnel that goes all the way around the cornea. And that's removed in a horizontal fashion. This is actually a case I just did 3 weeks ago. This is all we do during the quarantine. So yes, we are doing transplant. And you can see here as we remove the last bits of it, and then the corneal scleral button then is attached. And you can trim this to size as you go along, but the final appearance is like this. And you can see here, this is the patient that I was just showing. This is 1 week after the transplant. Anterior segment is deep, and the iris is relatively normal in this patient with normal pressure. This patient actually ran into the problem of elevated pressure. You can tell the iris is dilated from chronic acanthamoeba treatment and an infection. This patient actually has a tube shunt, a modified scleral dissection that I did here. There's a tube shunt in the anterior chamber, and this is actually the day after surgery. She's actually doing quite well as well. This is a previous patient. These patients, nicely, because it is a scleral keratoplasty, is that they have very little astigmatism. And this patient is about 5 or 6 years out from her surgery. Had one small rejection of her endothelium at one point, but maintains 20/25 vision in this eye, uncorrected after cataract surgery. So thank you very much for allowing me to participate in today's symposium. It's really an honor and a pleasure to see all of you. And I hope for the best through the pandemic as it burns itself out, and any other natural disasters that may occur. Thank you very much.
Thank you, Prof.